today's class. Today we are here to talk about the most important MCQs related to immunosuppressant drugs. Now, why did I choose this topic? Because I know this is one of the topics which students usually feel a bit difficult, and it is basically a overlap between the surgery and the pharmacology. So, hello here. So, I welcome all of you guys. So, hi Ramesh. Really sorry for a bit of delay. There was a bit of issue with the internet, so it is solved now. So, welcome to the class. I'll just wait for a couple of seconds so that students can join us. Whoever is here, just give me a thumbs up. I assure you this is going to be a good class. So, you will have kind of most of the MCQs in the immunosuppressive drugs will be covered today over here. So, just stay tuned, stay with me, and just wait for a couple of seconds so that students can join us, and then we'll be moving on. Fair enough, guys? So just give me a thumbs up whoever is online, and I'll be starting in a couple of seconds. So hi Harshita, hi Lumen, hi Hemant, all of you guys, I truly welcome you, and it's indeed a pleasure to have all of you with me. Okay, so yeah, just give me a second. I'll just be beginning in 1 second. Fair enough. So I think we should start, should we? Okay, so let us start and let us talk about today's session. Right. So the first question for the today's, and please guys, whoever is online, it's a humble request from my part, please answer, because I understand this part of kind of whatever the MCQs which we are discussing today may not be in the tip of your tongue or on the top of your mind, but please try to answer them, because if you try to answer them, you will understand where did you go wrong or what happened or something like that. Okay, so the discussion will be truly clinical. It will be based on only the relevant aspects. Okay, right. So let's move on with this particular thing. So the first question is, calcineurin inhibitors reduce the level of. A pretty simple question. What do you think is the answer, guys? So right, so Agarkar is basically up with the answer. He's saying that it's interleukin 2. Do you guys agree with him? So guys, whoever is online, it's a humble request, please do put up your answer. So Harshita is also saying it's interleukin 2. Well, yes, good. Okay, well, what is this? This is basically a calcineurin inhibitor. So yes guys, you're absolutely correct. Calcineurin inhibitors basically act by inhibiting the interleukin 2. Okay, very good. The answer is in fact B. Now let us talk about the next question. Fair enough, it's not interleukin 3, Ramesh, it is interleukin 2. Now let us talk about the next question, sirolimus. Okay, so we have a sirolimus, which is again an immunosuppressive drug. So what is the mechanism of action of sirolimus, guys? Can you please help me out with this? What is the mechanism of action of sirolimus? How does sirolimus acts? So I'm waiting for your answers, guys. Okay, fair enough. Okay, anybody else, guys? Right. So most of you are saying that it is C. Are you okay? Anybody else has any other opinion regarding it? What is the answer? Okay, well, the answer, very good, Pooja, Harshita and Vimal, really great guys, and also Agarkar, very good. The answer is in fact that it is an mTOR inhibitor. Okay, so very good, it is also correct, it is an mTOR inhibitor. Now let us have a look at how exactly do they act. So please understand, the sirolimus and the tacrolimus, what are these? These are the calcineurin inhibitors. So what are these? These are the calcineurin inhibitors. Now what they exactly do is, they go inside the lumen of the cell. So these sirolimus and tacrolimus, they go inside the cell, and inside the cell they go and they bind to calcineurin. Okay, so inside the cell they go and they bind to the calcineurin. And what is this calcineurin actually? So calcineurin is basically a phosphatase. Okay, so calcineurin is basically a phosphatase. And what happens, this drug and calcineurin जो product बनता है, this particular combination of a drug and the calcineurin, this together, this basically reduces the transcription of interleukin 2. Okay, so are you understanding my point? So definitely your answer was absolutely correct, that calcineurin and tacrolimus, they basically reduce the formation of interleukin 2. But how do they act? They basically go inside the cell. Inside the cell they combine with calcineurin. What is this calcineurin? Calcineurin is a phosphatase, it is an enzyme which basically helps in the transcription of interleukin 2. And if at all this cyclosporin and tacrolimus, they are going and attaching with this calcineurin, what will happen? This will inhibit the or reduce the transcription of interleukin 2, and this is how kind of interleukin 2 levels are reduced. Okay, so this is something to know about. Now another important thing is sirolimus. Now please understand, sirolimus is very much similar to the tacrolimus and this cyclosporin in terms of where it acts and how the molecular structure is. Okay, so tacrolimus and the sirolimus, they kind of sound also similar, so they are very much similar if at all you talk about the molecular structure of these particular two drugs, but the mechanism in which they act, this is absolutely different. Okay, so how does an mTOR inhibitor act? So please understand, sirolimus, it is an mTOR inhibitor, very well told by you guys, but how does it act? How does mTOR inhibitor act? So mTOR inhibitor, it doesn't kind of interfere with the formation of interleukin 2. What it interferes with? It interferes with the intracellular signaling of the interleukin 2. Okay, so it allows the interleukin 2 to form, but it interferes in the way the interleukin 2 is kind of affecting a cell or kind of developing a cell. Are you understanding my point? So molecularly, these two are very much similar, sirolimus and tacrolimus, but the method or the process by which they act, that is entirely different. Okay, I hope you got this. Fair enough. Let's move on to the next question. Now, gingival hyperplasia, this is a side effect of. So this is a side effect of sirolimus, tacrolimus, both or none. Okay, so you know that kind of calcineurin inhibitors, they basically are responsible for the hirsutism and the gingival hyperplasia. What I'm trying to ask here is gingival hyperplasia, this is basically a side effect of which drug? Is it a side effect of cyclosporin, tacrolimus, both or none? Okay, so what is the answer, guys? I'm waiting for your answer. So what is the answer, guys? Can you please tell me? Whoever is online, please do tell me, guys, what is your answer? None. Okay, agar ka, fair enough. Fair enough. Okay. Anybody else, guys? So Ramesh is saying it's A. Fair enough. Anybody else? What about Pooja, Harshita, Vimal? What is the answer, guys? Can you please tell me? And whoever is whoever is watching us at this particular moment, please do kind of tell this particular thing. What is the answer? Okay. So Raghu is saying it's A again. Okay. What about Harshita and Vimal? What do you think is the answer, guys? Well, the answer to this particular question is in fact A. Okay, so answer is in fact cyclosporin. Please understand. So cyclosporin and tacrolimus both are the calcineurin inhibitors. In our mind, usually we feel that it is. We usually feel that these like all the calcineurin inhibitors are basically responsible for the hirsutism and the gingival hyperplasia and all those things. But please understand, they are much more associated with sirolimus. Okay, so yeah, cyclosporin. Okay, I'm really sorry. It is much more associated with cyclosporin. Now moving on to the next MCQ, the development of diabetes. So we also know that kind of calcineurin inhibitors, it associated with the sometimes if you start the patient on these particular immunosuppressant drugs, patients have kind of rearrangement in their blood sugar levels. So that is a side effect of what? Is it a side effect of cyclosporin, tacrolimus, both or none? What is the answer, guys? Okay. So Priyanka is saying it is both. Fair enough. What else? What is the answer to this particular question? Diabetes. Okay. So Agirka is saying it's both. Fair enough. Anybody else, guys? Okay. Ramesh also is saying both. So most of you are saying it's both, right? Well, the answer is in fact tacrolimus. Okay. So please understand, the development of diabetes, it is much more common with tacrolimus. Okay. So answer is basically B. Okay. Well, so let us have a look at this. This is such a wonderful table given in 11 Billy, which basically summarizes the side effects of most of the immunosuppressive drugs. Okay, so let us have a look at this. Okay, so here we have a cyclosporin. So the nephrotoxicity, hypertension and dyslipidemia, that is common with both cyclosporin as well as tacrolimus, but hirsutism and gingival hyperplasia, they are associated with cyclosporin. What about the tacrolimus? It is associated with diabetes. Okay, so did you get it, guys? Please understand. I'll just talk to you about this. Calcineurin inhibitor, cyclosporin, tacrolimus, both. Cyclosporin, this is associated with all the other which is common is fine, but this is specifically associated with gingival hyperplasia and hirsutism, and tacrolimus is the one which is associated with the diabetes. And the common side effects between these two is the nephrotoxicity, very very important side effect. We also have something which is called as a calcineurin inhibitor associated nephropathy, in which is of very much importance in renal transplant patients. Then hypertension and dyslipidemia, these are the side effects of cyclosporin and tacrolimus. Okay, fair enough. Okay, let's move on. Right. So please understand, Priyanka, yes, cyclosporin does cause hyperglycemia, but it is to a very, very limited extent. So this question has already been come. They did ask you to choose between calcineurin and tacrolimus. And if at all you have to choose between one, you have to go for a tacrolimus. And if you just look at the particular table which is given here, Levin Bailey, in the kind of a column, the cyclosporin, it doesn't mention diabetes over there. Okay, so I just showed you the table from one of the most standard books of surgery which you have, that is Levin Bailey, and this has already been tested. Okay, so please understand, diabetes, it is most commonly associated with tacrolimus. Okay, that's why I put up that particular question, Priyanka. Okay, let's move on. Let's talk about this particular thing. Now, immunosuppressive drug which augments the effect of calcineurin inhibitors. Okay, so we have a calcineurin inhibitor. I just told you how does it act. Now, which of these immunosuppressive drugs which augments the effect of calcineurin? Okay, so what is the immunosuppressive drug which augments the effect of calcineurin? Can you please tell me, guys? Okay, so Ramesh is saying it's mTOR inhibitor. Fair enough. Anybody else, guys? Guys, I completely understand. These are a bit more detailed questions, but please try to attempt whatever you feel like, okay? Don't kind of hesitate in answering the kind of questions, because whatever is in your mind, just take it out and then we will break it down and understand how exactly it works, okay? So thank you so much for answering, Ramesh, and I please encourage others to answer. So please answer, guys. So thank you, Raghu. And yeah, what about Priyanka, Harshita, Pooja? What is the answer, guys? So azathioprine, fair enough. Dua is saying okay, again azathioprine. So okay, so kind of a mixed response. What you guys trying to tell me is mTOR inhibitors and azathioprine. Okay, fair enough. Okay, well guys, what is the correct answer to this particular question? IL-2 receptor blocker. Okay, fair enough. Right. So this is something which is good. Priyanka is kind of very very close to answer, but what is the IL-2 receptor blocker in here? The answer is anti-CD25, guys. Okay, so answer is actually C. Okay, so Priyanka was very very close to this particular question. Okay, so now let us come back over here. So how does this calcineurin inhibitors act? So calcineurin inhibitors, basically they act by kind of reducing the transcription of interleukin 2, and these interleukin 2 act on anti-CD like CD25 receptors. On the T lymphocytes there is a CD25 receptors on which this interleukin 2 acts. Okay, so what augments this? It is anti-CD25. Okay, I hope you get this. So this is how like we augment the effect of the calcineurin inhibitors. Okay, so calcineurin, this basically inhibits the transcription. It inhibits the transcription. And what exactly this happens, if at all the interleukin 2 is acting, whatever the little bit of interleukin 2 is being produced, it is not being able to get attached to the CD25 because of anti-CD25 drugs which we have. Okay, so I hope you got this. This is again a direct line from Levin Bailey, so this can be asked. So you might argue with me that even the mTOR inhibitors do the kind of similar thing, but please understand this is actually a direct line from Levin Bailey, which basically writes that which drug augments the calcineurin inhibitors? The answer is anti-CD25. Okay, so if this kind of a question comes, please go for anti-CD25. Fair enough. Why not mTOR? I knew that this kind of question is going to come, but please understand this is again a direct line from Levin Bailey, and if at all such kind of question comes, yeah, I completely get your point that mTOR inhibitor also kind of doesn't let the interleukin to act in a proper manner, but please understand the answer to this particular question is anti-CD25, direct line from Levin Bailey. Fair enough. Yeah, so the reason is because interleukin 2, by entering into this, so it kind of inhibits it. But here, whatever the little bit of interleukin 2 is acting, and if at all you are kind of completely blocking the CD25, even if the bit of a potency of this interleukin 2 is remained after the mTOR inhibitor, still it will not be able to act. Okay, so it is a complete blockage of the receptor. Are you understanding my point? mTOR inhibitor will basically reduce the efficacy of interleukin 2, but it will not completely block the CD25 receptor. So a part of it is not able to be formed, and whatever the remaining is formed, it is not allowed to get attached to the CD25. Okay, so please understand this particular aspect, and yeah, fair enough. Right, now moving on, which of the following is not an adverse effect of mTOR inhibitor? So now talking about the side effects of mTOR inhibitor. Okay, so what of the following is not an adverse effect of mTOR inhibitor? Delayed wound healing, deranged lipid profile, nephrotoxicity, and pneumonitis. So what is the answer to this particular question, guys? Okay, so what is the answer to this particular question? Can you guys please tell me? Right, so what is the answer? Harshita, Ramesh, Pooja, Hemant, Vimal, what is the answer? So Ramesh is saying it's C. Okay, Dua is saying it's B, Pooja is saying it's B. Deranged lipid profile, fair enough. Okay, fair enough. Anybody else, guys? Anybody else? Please be fast and please answer. Okay, well, the answer to this particular question is in fact nephrotoxicity. Please understand, nephrotoxicity is not an adverse effect of mTOR inhibitor. Why? Okay, so this is a why. I mean, there's no why with this, but please understand, mTOR inhibitor, they don't cause nephrotoxicity. Okay, now why is this important for us? Why are we so much stressing on this particular point? Because please understand, calcineurin inhibitor. Okay, so first let's go to the table. What are the side effects of the mTOR inhibitor? We have a thrombocytopenia, then dyslipidemia, then pneumonitis, and impaired wound healing. Now this is again a very, very important MCQ. They keep on asking you this impaired wound healing. It is a side effect of mTOR inhibitor. Pneumonitis, thrombocytopenia, and dyslipidemia, all are the side effects of mTOR inhibitor. Now let us talk about why are we so much worried about this particular thing. Because please understand, the calcineurin inhibitors which we have, these are basically the mainstay of the drugs of the immunosuppression. Now let's assume you have someone with a kidney transplant, okay? And one of the important kind of side effects of calcineurin inhibitors, what exactly is one of the very, very important side effects? It causes nephrotoxicity, okay? So it causes nephrotoxicity. Fair enough? Now, if at all, I did tell you that calcineurin inhibitors induce nephrotoxicity. It is a very, very serious condition. And if at all you have done a renal transplant, you don't want this to happen. So what you can do is you can replace for the maintenance, in the maintenance phase, you can replace the calcineurin inhibitors with the mTOR inhibitors, because these mTOR inhibitors, they will not lead to this nephrotoxicity. Now, you might argue with me, why not start the patients on mTOR inhibitor? Why you should not start the patients directly on the mTOR inhibitor? Because of delayed wound healing. Okay, so I hope you get this. This is one of the side effects of mTOR inhibitors, and if you go for this, the patients might develop lymphocele or the wounds might not heal properly. So that is why you avoid mTOR inhibitors in the perioperative period. But once the healing of the wound and everything is fair enough, and then you can replace the calcineurin inhibitors with the mTOR inhibitor. Okay, I hope you got this particular point. Fair enough. Can we move? Right. So let's move on to the next question. Now, immunosuppressive drug associated with an increased risk of PTLD, that is post-transplant lymphoproliferative disorder. Okay, so which of these drugs is associated with increased risk of PTLD? What is the answer, guys? What is the answer? Can you please tell me what is the answer? So whatever I have kind of put up in these particular questions, they are truly from Love and Bailey. So yeah, just go through them. What is the answer, guys? Please, can you please tell me what is the answer to this particular question? Okay. So Pooja is saying it's C. Ramesh is saying it's B. Fair enough. Anybody else? Okay. Hemant is saying it's T. Okay. So all the mixed responses. What about Raghu? What about Harshita? Pooja? What is the answer? Dua is saying it's T. Harshita is saying it's T. Okay. Fair enough. Okay. Vimal, what is the answer? Well, guys, the answer is, I really do not expect you to know this particular thing or maybe to remember it on the top of your mind, but I'm just trying to pinpoint it to you so that you will maybe remember it for the next time. So please understand, it is this belatacept. Now, what is this belatacept? I've kind of very much twisted this particular thing. So please understand, there is something which is called as a CTLA4 immunoglobulin receptor. Okay, so this is basically used as one of the treatment options, which is I'll show in the where it is used, but please understand this is a new drug which is being coming up, and it is a very promising drug. Why? Because this may replace the calcineurin inhibitors, because as I told you, one of the very basic, like, grave thing which we face with the calcineurin inhibitors is the nephrotoxicity. So this, if at all it can replace the calcineurin inhibitor, is a very good thing, because the nephrotoxicity will not happen. But this particular agent, the example of this is this belatacept, and this is the one which is responsible for increased PTLD. Okay, so yeah, just remember this. Okay, even if you did not get this, that's completely fine, but please understand this belatacept, this is this CTLA4 immunoglobulin, and this is being used as a substitute for calcineurin inhibitors, not yet approved till now, but maybe in the near future this will be approved. Fair enough. Now this belatacept is given in your kind of a text in your Lovin Belly, so yeah, you have to know that particular thing. Moving on. So this slide basically summarizes all the drugs which we just talked about, so let us go through it. Okay, so what do we have? We have resting T cells which are converted to the early activation, the late activation, then the proliferation. So all these drugs which we just talked about in bits and parts, they act at different stages of this cell proliferation. Okay, right. So now let us talk about each drug. So the one which I just talked about is a belatacept. This is basically a co-stimulatory blocker, and this is CTLA4 immunoglobulin. Okay, so are you understanding? This is acting very much ahead in the kind of progression of these T cells. So that is why whatever the drugs which are acting on this particular level, which are the depleting antibodies and the co-stimulatory blockers, these are very potent drugs. Okay, so if somebody asks you which of these is a very potent drug, the answer is alemtuzumab, ATG, and the depletion, like these are the depletion antibodies, and then we have a co-stimulatory blockers. Are you understanding my point? Why are they very much potent? Because they are restricting the growth of the T cells or the maturation of the T cells right at the beginning. Okay, but they are very potent. So yes, they will prevent the kind of transplant rejection, but at the same time they will cause more immunosuppression, they will cause more risk of malignancies, and they will cause more susceptible to the infections. Okay, so these are also the side effects of the drugs which are acting in the ahead, like in the first part of this maturation phase. And if you just try to correlate, that is the reason why belatacept is associated with PTLD, which is basically a type of a malignancy. Okay, so it is a malignant like reaction, we'll talk about that too. But yeah, this is the early phase of the malignant kind of reaction which happens. Okay, so now you get it, because it is acting in the early phase, it is causing more immunosuppression, and that is why the risk of malignancy is more in this particular patient. Okay, I hope you got this. Fair enough. Now what is this alemtuzumab? This is anti-CD52. Okay, so just a point for you to remember. Then for early activation phase, what do we have? We have this calcineurin blocker, and we already talked about how does it act. So cyclosporin and tacrolimus, they go inside the cell, bind to the calcineurin, and this drug and calcineurin kind of the combo, this basically inhibits the transcription of interleukin 2. This is how the calcineurin inhibitors, calcineurin blockers act. One of the very important side effects of this is nephrotoxicity, which is common for both cyclosporin. This is associated with gingival hyperplasia and hirsutism. Tacrolimus, this is the one which is associated with the diabetes. Fair enough. Then what we have this anti-CD25. What are these anti-CD25s? These basically block the receptors CD25 on which the interleukin 2 will come and attach. So these are basically the one which augment the effect of calcineurin blockers. Then we have a Mtor blockers. So Mtor blockers, these are basically the sirolimus and the everolimus, and these basically inhibit the late activation of the T cells. Finally, we have anti-proliferative agents which are azathioprine and the mycophenolate. Okay, so these are all the drugs, all the immunosuppressive drugs which we use in the patients of transplant. Okay, so I hope you got this. So this slide basically summarizes, if you just kind of understand this particular slide and try to remember this particular slide, most of the things will be clear to you. Fair enough. So now, till now, what we have talked about the individual drugs, and now we are going to talk about the immunosuppressive regimens which we use. So it is not very specific, but yes, in most of the transplant, it is a very kind of a famous triple therapy. It is also referred to sometimes as a cocktail therapy. So if at all somebody asks you what is this triple therapy or a cocktail therapy used in the immunosuppressive agents, it is kind of understood what do they mean. So which of these following drugs is not included or is not a part of this triple therapy or this cocktail therapy? Can you please tell me? So yeah, immunosuppressive agent which is not a part of the triple therapy. Is it a calcineurin inhibitor, mTOR inhibitor, anti-proliferative agent, or a steroid? So what is the answer to this particular question, guys? I want you to answer. What do you think is the answer to this particular question? So Pooja is saying it's B, mTOR inhibitor. Fair enough. Anybody else? Okay. So Pooja is kind of telling you that it is B. Fair enough. Anybody else wants to attempt this particular thing? Right. So Agarkar is saying it's anti-proliferative agent. Anisha is saying it is B. Okay, mTOR. So Raghu is also saying it's B, that is mTOR. So most of you are going up for B, guys. Okay. So Pawan is saying it's C. Fair enough. Ramesh is saying it's B. Okay. The answer is absolutely B. Okay, very good. The answer is in fact mTOR inhibitor. Very, very good. So the cocktail regimen or the triple therapy which we basically use is, because I have already told you that calcineurin inhibitors, these are basically the mainstay of the immunosuppressive agents. So definitely A is going to be the answer. And along with this, we have this anti-proliferate agents which we saw at the last, and the steroids. So these are the parts of the triple therapy or the cocktail regimen, and mTOR inhibitors are not a part. Why? Because this has to be initiated just after the surgery. I already told you we avoid the mTOR inhibitors just after the surgery. mTOR inhibitor is basically used to replace the calcineurin inhibitor as a kind of a maintenance drug. Okay, so all things kind of connecting the dots. Okay, if you just connect the dots, you will remember this. This I talked about as a triple therapy. Now there is also sometimes referred to as a dual therapy. So nothing great about this. If at all somebody asks you about the dual therapy, so the dual therapy consists of calcineurin inhibitor with an anti-proliferative agent or a calcineurin inhibitor with a steroid. But the calcineurin inhibitors is the mainstay of the treatment in the immunosuppressive agents in the transplant patients. I hope you get this particular point. Fair enough? Yeah. So triple therapy, calcineurin inhibitors, anti-proliferative agents and the steroids. Double therapy, it is calcineurin inhibitor with an anti-proliferative agent or a calcineurin inhibitor with a steroid. Fair enough? Right. Now, I just told you the triple therapy is calcineurin inhibitor with anti-proliferative agent and the steroids. And in fact, most of you knew this, so it's a great thing. Yeah. Now, the patients on immunosuppressive therapy are at the maximum risk of infection with, okay? So if at all you put a patient on a immunosuppressive therapy, what is the maximum risk which will occur in this particular patient? Will they suffer from a bacterial infection, viral infection, fungus, or a parasitic infection? What do you think is the answer, guys? So what do you think is the answer? So Ramesh is saying it's B, Hemant is saying it's C. Fair enough. Anybody else? Okay, so Agarkar is again saying it's viral, that is B. Fair enough. Anybody else, guys? Please put up your answers a bit fast. Right. Yeah, so Raghu is saying it's B. Fair enough, guys. The answer is in fact B. Okay, so what is the answer to this particular question? The maximum risk of infection which occurs with immunosuppressive therapy is in fact a virus. Okay, so good, very good. Okay, so it is B. Good. Now, let us talk about this. Now, risk of bacterial infection. So it is not like others will not occur. Definitely bacteria and fungus, they can also infect these particular patients. But the most maximum risk is of viral infection. Okay. Now, the next question which I am trying to ask you is, if at all the bacterial infection is about to happen, what is the kind of the risk of this suffering from a bacterial infection? It is maximum. For how long after the transplantation? So during what time you have to be extra careful for the bacterial infection? So is it for 1 week? Is it for 1 month? Is it for 6 months? Or is it for 1 year? Okay. So what do you think is the answer to this particular question? So what is the kind of infection for which you have to be super careful as far as the bacterial infection is concerned? What is the answer, guys? Can you please tell me? Right. I want an answer, guys. So Agarkar is saying it's A, Pooja is saying it's B. Yeah, 6 is fine, but what 6? Hemant? Yeah, so you all guys are battling between B and A. What is the answer, guys? So Manik, hi, good to have you. Right, so Raghu is saying B. Fair enough. So you guys are saying for the bacterial infection, we should be very careful for 1 month. So well, yes, the answer is in fact 1 month. Good, great. Okay, for the bacterial infection, we have to be extra careful for 1 month. But now, if I just change the question and make it to virus, okay, so if I make it a viral infection, what is the maximum risk with the viral infection? For how long is the maximum risk? So, right. So, Manik, I missed you in the kind of plus class today. Do see the recorded version. I just covered inflammatory bowel today, disease today. Maybe you're busy or something. Just have a look at it in the recorded form. Fair enough? Right. So the risk of the viral infection of the is maximum for how long after transplantation? Please attempt this particular question, guys. What is the answer to this particular question? The risk of viral infection is maximum after how long after transplantation? What is the answer? So most of you are saying that it's A. Okay, Bretley is saying it's A. Hemant is saying it's A. What about Pooja, Raghu? Yeah, fair enough, Manik. I just missed you. That's it. Nothing great. I'm sure you must be having some work or something. Fair enough. So Nitika is saying it's C. Fair enough. Anybody else, guys? So, well, Nitika, thank you for the answer. In fact, the answer is C, guys. Okay. So please understand. I'll just break things down for you. The maximum risk of infection is with the virus, but the maximum risk or maximum duration in which the infection can occur bacterial, it is 1 month, and the viral infection, it is for 6 months. Okay. Please understand this. And do I have this? I don't have this. But if I just change this particular question to a fungus, okay, so if I just, okay, so I just told you for the bacteria we have to be super careful for how much time? We have to be super careful for how much time, guys? For 1 month. For virus we have to be super careful for 6 months. And what about for the fungus? For the fungus, what is this duration? I did not put up an MCQ, I'll just directly tell you. So please understand, for the fungus, we have to be super careful for 3 months. Okay. Now, I do get this. These are all the arbitrary figures, but these are the figures which are given in your 11 Billy. And at least for your Neet PG, you have to focus on these particular things. Okay. So please understand, the maximum risk of infection with the bacteria is for 1 month, virus is for 6 months, fungus is for 3 months. Okay. I hope you got this. Now, the most common viral infection occurring in a transplant patient. So you did tell me that most common organism which can infect your transplant patients, it is virus, and the maximum risk is for the first 6 months. What I'm trying to ask you here is, what is the most common viral infection which can occur in a transplant patient? It is a herpes simplex virus, Epstein-Barr virus, cytomegalovirus, or a hepatitis B virus. What is the answer, guys? So, what is the answer? So, most of you are up with the answer and you guys are pounding upon cytomegalovirus. So yes, definitely the answer is in fact a cytomegalovirus. Kudos to you. Very good. The answer is in fact a cytomegalovirus. Okay. Now let us move on to the next particular question. Now please understand, this is a very, very important question again. Now the most effective prophylactic agent against the cytomegalovirus in the post-transplant patients is, I'm asking most effective. Okay. So what is the most effective kind of prophylactic agent? So if at all there is a maximum risk of cytomegalovirus infection, so in the post-transplant patients, what we do, we give them chemoprophylaxis. We put them on certain drugs which are being continued for a prolonged period of time so that they don't develop this particular infection. It is kind of a preventive measure. So which of these drugs is most effective in preventing the cytomegalovirus infection? Acyclovir, valcyclovir, valganciclovir, or a ganciclovir? What is the answer, guys? So right. So I think the answer started from Anisha, I think. So most of you are answering it as D. So Raghu is the one who is answering it as C. Anybody else wants to say what is the answer? So answer to this particular question is in fact C, guys. Okay, so please understand. Valganciclovir. This is the drug which is most effective prophylactic agent. Okay. Now, okay, fair enough. Now, let us talk about this particular question. Okay, I don't have that particular question. Okay, now if I just ask you randomly that if at all the patient is suffering from cytomegalovirus, okay, so the infection has already occurred. Now, what is the treatment? What treatment option you can go for this particular patient? What is the treatment option which you can go for this particular patient? Can you please tell me? So if at all the cytomegalovirus infection has occurred, now the patient is coming to you with the signs and symptoms, what is the kind of treatment? How will you treat this particular patient? How will you treat this particular patient? Ganciclovir. Okay, so the options which you have are, it is ganciclovir. Fair enough. Okay, so you have a ganciclovir and you have valganciclovir. Right. Now, what is better? So ganciclovir is better. Okay, so now please understand one thing. If at all the patient is suffering from a cytomegalovirus virus infection, he's coming to you with an infection, for the treatment you give ganciclovir. Fair enough. Ganciclovir is in fact a better drug as compared to the valganciclovir. But can anybody please tell me why were we not giving ganciclovir as a prophylactic for a prophylaxis? Why the answer here is not ganciclovir? Why it is not ganciclovir? Because ganciclovir is a better drug, right? So why we don't give ganciclovir as a prophylactic agent? Can you please tell me? So Priyanka, yes, absolutely correct. Drug of choice for cytomegalovirus is ganciclovir. Fair enough. But why were we not giving ganciclovir as a prophylactic agent? The answer is because the ganciclovir is given IV. Okay, so it is an intravenous treatment. What about the valganciclovir? This is an oral agent. Okay, so we have this orally. And ganciclovir, this is an intravenous agent. So now you get it why we don't give ganciclovir for a prophylaxis, and obviously because it is an IV agent, the effectiveness for the treatment of the cytomegalovirus, that is the ganciclovir. So I think now the things are kind of right in tune with you. So Raghu, very good. It is an oral, very good. Fair enough. Right, now let us talk about this herpes simplex virus infection in the transplant patients present as. So if at all you have a HSV infection in the transplant patient, how will the patient present to you as? Will the patient present as pneumonitis, retinitis, mucocutaneous lesions, or an encephalitis? So yeah, so no doubt the most common infection which occurs is the cytomegalovirus, but sometimes patients can also present with a HSV infection. So if at all there is an HSV infection in this particular patient, how will the patients present to you? So I'm getting a kind of a mixed response between C, A and D. So what is the answer, guys? Okay, fair enough. So guys, answer to this particular question is in fact a mucocutaneous lesion. So please understand this HSV, herpes simplex virus, this usually present as a mucocutaneous lesion in these particular patients. Okay, so yeah, please understand mucocutaneous lesion is the presentation of HSV infection. Now what about the CMV? How does the CMV presents? Cytomegalovirus, which is the most common kind of a virus which is affecting the transplant patients. How do these patients present? So these patients present with pneumonitis, retinitis, encephalitis, and gastrointestinal symptoms, GI symptoms. Okay, so these patients present with all these things. So CMV presents with retinitis, it presents with pneumonitis, it presents with encephalitis and the GI symptoms. Okay, cytomegalovirus is the one which presents with this. Okay, so please understand this particular point can be asked you. Right, now let us talk about the next question for the today. Virus most commonly associated with a graft dysfunction in the renal transplant. So if at all you have done a renal transplant and the virus which presents as a graft dysfunction, and if at all it is present and you have done a renal transplant, so the virus which is most commonly associated with a renal failure. So what is the answer to this particular question? Is it cytomegalovirus, herpes simplex virus, BK virus, or Epstein-Barr virus? What do you think is the answer? So okay, so I'm getting answers. Agirkar is saying it's A. Somebody said it is a herpes simplex virus. Pooja is saying it's A. Nitika is saying it is C. Fair enough. Brett Lee is saying it's B again. Manik is saying it's C. Okay, answer to this particular question is in fact C, guys. Okay, so BK virus. Now, three things which you need to understand about the BK virus is BK virus is the one which is associated with the graft dysfunction. Okay, so three things which you need to understand about the BK virus. Okay, so we have a BK virus. Three things which you need to remember about the BK virus is that it is associated with the graft dysfunction. So it is associated with the graft dysfunction in renal transplant. Okay, so it is associated with the graft dysfunction in the renal transplant. First thing. Another thing which you need to understand about this is this can present in a dormant form. Okay, so what actually happens is this BK virus, this is present in the epithelium of the urogenital system. This is present in the epithelium. Now, because the body's immune system is good, this is kind of contained in those epitheliums. But what happens if at all you do a renal transplantation, you start the patients on immunosuppressive drugs, and if you start the patients on immunosuppressive drugs, what happens? The ability of the body to fight or to keep the BK virus limited to those particular cells, it is reduced, and these dormant forms, they become activated and they present as a graft dysfunction. Okay, and if at all this is a thing, how will you treat this particular patient? What is the drug of choice? Can anybody tell me what is the drug of choice? What is the drug of choice for this particular patients? So the drug of choice for this particular patients is, in fact, the drug of choice for this particular patients is reducing the immunosuppression. Okay, so immunosuppression, this presents as reducing the immunosuppression. Okay, so what I did ask you, virus most commonly, so I'm not disagreeing that maybe Epstein-Barr virus can also present as a graft dysfunction. The question said most commonly associated. Okay, so Raghu, that is why the answer is BK virus. Okay, so what I'm trying to do here is, understand guys, whenever the questions come, they will always ask you about the most characteristic feature of those particular things. So if at all anything, if you wish to remember about the BK virus in the post-transplant patients, these are the three things. Okay, so the first thing, they present as a graft dysfunction, they are present in a dormant form. What happens actually is, most of the children are already affected with this BK virus. Okay, and when you give the immunosuppression, the immune system kind of drops down, and that is why they become activated and they present with a graft dysfunction. The treatment, how you want to treat this, there is no drug for this. All you need to do is, you need to reduce the dose of immunosuppression. Are you understanding my point? I hope you got this. Okay, fair enough, right? So let's move on to the next particular question. The most common fungal infection in the transplant patients. Okay, so all can be present in the transplant patients, no doubt about it. But what I'm trying to ask you is, which is the most common fungal infection which can occur in the transplant patient? What is the answer to this particular question? So can you please tell me guys, what is the answer to this particular question? The most common fungal infection occurring in the transplant patients. What is the answer? So Agarkar is saying it's B, that is pneumocystis. Anybody else guys? Okay, Anisha is saying it's B. Okay, fair enough. So all of you are saying it's B. Very good. So Nitika, no, answer is not Candida. Answer is in fact pneumocystis. Very good guys. Very good. So others can also occur, but yes, pneumocystis is the one which is most common fungal infection which is occurring in the transplant patients. Fair enough. Good guys. Very good. Right? Okay. Right. And another important thing is, what did I tell you? That what is the maximum risk of infection with the fungal infection after the transplant? What is the maximum risk? It is for the 3 months. So the maximum risk is occurring in for the 3 months. But if at all I ask you, you will have to again go for a prophylaxis. Okay. So prophylaxis, this needs to be continued for how much time? So this prophylaxis needs to be continued for 6 months. Please understand this. You don't reduce the time period of a prophylaxis. The prophylaxis will be continued for the 6 months, but if at all somebody asks you what is the maximum risk, the maximum risk is for the 3 months. So may it be viral, may it be kind of a bacterial, may it be fungal, you continue the prophylaxis for 6 months. But what I wanted to tell you in that particular slide is, the maximum risk for the bacterial is 1 month, fungal is 3 months, virus is 6 months. Fair enough. Moving on. Now, so now we have talked about the infections. Now it's time to talk about the malignancies. So the most common cancer occurring in the transplant patients. So what is the most common cancer which is occurring in the transplant patients? Can you please tell me what is the most common cancer which is occurring in the transplant patients? Can you please tell me guys? Right. So again, this is not, this is a very, very simple question. Okay. Right. So Priyanka is saying it's PTLD. Hemant is saying it's B, D, A. I've got all sorts of answers. So B, D, and kind of A and C. Okay. So I've got all the answers. What is the answer to this particular question? Okay. So guys, this should not be done wrong. Okay. So this is a very, very simple question. It's a repeat question. Answer to this particular question is a skin malignancy. Okay. So the most common cancer occurring in the transplant patients, it is a skin malignancy. I hope you got it. Okay. Please understand. Please don't do it wrong. And which skin malignancy? So you have a squamous cell carcinoma, and what do you have? You have a basal cell carcinoma and you have a melanoma. So out of these, which is the most common malignancy which is occurring in these particular patients, in the transplant patients? So guys, answer is B. No doubt it is B. Okay. Now in B, what is the most common skin malignancy which is associated with this particular transplant recipient patients? What is the answer? Okay, so Yogesh is saying squamous cell, Pawan is saying squamous cell. Pawan, why did you take it off? You are right. You are absolutely correct. The answer is in fact squamous cell carcinoma. Okay, so answer is squamous cell carcinoma. Okay, yes. Answer is squamous cell carcinoma. Ramesh, it is not melanoma, it is a squamous cell carcinoma. Please understand. Now, what about basal cell carcinoma and melanoma? If somebody asks you that the risk of basal cell carcinoma and melanoma as compared to the general population, is the risk increased in the transplant patients? The answer is yes. The risk of basal cell carcinoma and the melanoma as compared to the transplant patients, the risk is increased in the patients of transplant recipients, okay? But amongst these three, the most common malignancy which is occurring in the transplant patients, no doubt it is a squamous cell carcinoma. Fair enough? Right. Now, maybe the last MCQ for today, virus most commonly associated with PTLD, okay? For the post-transplant lymphoproliferative disease. So what is the virus which is most commonly associated with the PTLD? What is the answer to this particular question, guys? Can you please tell me? Important. What is the this is again a very, very important thing, okay? So the virus which is most commonly associated with the PTLD, we did saw the drug which was causing an increased risk of PTLD. Now what I'm trying to ask you here is, what is the virus which is most commonly associated with the PTLD? So Harshita is saying it's T, Nitika is saying it's T. What is the answer, guys? What do you think is the answer? Priyanka is also saying it's T. Fair enough. What is the answer, guys? Good. All of you are absolutely correct. The answer is Epstein-Barr virus, okay? So yes, very good. So virus which is most commonly associated with the PTLD infection, it is an Epstein-Barr virus, okay? Right. Now let us talk about PTLD. What is this PTLD? This is post-transplant lymphoproliferative disease. Now, what is this? This is basically a kind of a malignancy which is occurring. So it is basically a proliferation of the lymphocytes. That is what is happening in these particular patients. So a couple of things which you need to understand in this is, it is associated with an Epstein-Barr virus, fair enough. Another important thing is, what will be the clinical features of this particular patients? So please understand, these patients will usually present to you with lymphadenopathy, okay? Lymphadenopathy and tonsillitis, and sometimes there will be involvement of a respiratory system also. Respiratory system can be involved, okay? Right. Now, what does it sound similar to something? So it sounds similar to infectious mononucleosis, right? Infectious mononucleosis. Because infectious mononucleosis also presents with similar kind of thing. Generalized lymphadenopathy, tonsillitis, respiratory system involvement. So please understand, these are kind of a differential diagnosis. But if at all in the kind of a history of a immunosuppressive drugs given and there is a lymphadenopathy, tonsillitis, respiratory system, most probably it is a PTLD, okay? So if at all you get a clinical scenario in which the patient has suffered from a transplantation on the immunosuppressive drugs, now present you with a generalized lymphadenopathy, what is the virus which is responsible for this? It is not cytomegalovirus, it is a Epstein-Barr virus, okay? So please understand this. Another important thing is, how do you treat this particular patients? So in these particular patients, you may go for a chemotherapy and a radiotherapy also, and sometimes you put the patients on rituximab, that is a anti-CD20 antibodies, okay? But please understand, sometimes you have to go for a radio and chemotherapy in these particular patients, and obviously you reduce the immunosuppressive drugs so that the immune system of the body can again regain, okay? So this is all about the whatever about the immunosuppressive drugs which I wish to talk about. Now this particular session deliberately have conducted in a lot more detail. So why I have conducted this in a lot more detail? Because I just wanted to tell you that we have launched the foundation course, okay? So we have launched the foundation course in our Plus platform, and in this Plus platform, entire general surgery will be covered in such a manner, and it will be entirely parallel to Love and Bailey. Now, if you just go back and if you just read the immunosuppressive drugs from Love and Bailey, you will not have a single issue and you will be able to read the entire chapter within 20 minutes, okay? So, yeah, this was in lots and lots of detail. In the foundation course, I'll be teaching general surgery for 100 hours. And in this, I will be teaching general surgery, every aspect of it, I'll be teaching in such a manner. So, it was just to give you a glimpse about what are we doing on our Plus platform. So if at all you find that entire general surgery, or for that matter all the subjects are covered in such a manner, might add up to your preparation, might benefit you in your final preparation, I request you guys just to come on Plus platform and have a look at it, because it was such a pleasure to see like so many students kind of coming and interacting on the YouTube, and I'll be more than happy if all of you just come and interact with us on the Plus platform also. In the Plus platform, all the things are in such an interactive manner also, right? So the question which I'm getting by the Hemant is when it will start. So foundation course has already started. My surgery lectures on the foundation course will start in the month of end of April or start of May. And at this moment also, I am conducting lots and lots of kind of small courses directed, like taking into consideration the upcoming aims. And in the month of April, what I've planned is, in the month of April, every time kind of exams come near, so most of the students ask me what are the most important topics in general surgery. So what I've decided, in the month of April, I will be conducting around 22 hours rather, or 22 hours of most important topics in general surgery. So I'll be covering around 350 topics in general surgery in 22 hours. There will be 11 sessions, 2 hours each, and in this I will be tackling about 300 to 350 most important topics about general surgery. In the foundation course, I'll be talking about each and everything in detail, but in these 22 hours, I'll be talking about the most high yield topics. Okay, so if at all you want a quick brush up about, or you want to just revise general surgery with me, this courses will definitely benefit you. And also there are lots and lots and lots of courses on the Plus platform. If you take up a subscription, you will have unlimited access to all these courses. So I just request you, just come and have a look at it. And we are in the process of launching our own kind of structured notes as well as the Q bank, which will be available to you guys very, very soon. Okay, so I'm not trying to sell an academy. What I'm trying to do is, I'm just trying to educate you about the platform, because we are doing our best to make this platform a really, really great platform. It will, like, the response is good. Whoever is coming up, they are really kind of appreciating this particular thing, and I want you to just come and experience it. Okay, so thank you so much for attending this particular session. It was indeed a pleasure. I hope whatever we discussed today added some value to you. You join an academy, you don't join an academy, that's completely fine. All I wish is all the best for you, and we will continue this kind of free sessions for the entire year. You can come, you can interact with us over here, but if at all you come and join us on the Plus platform, it might benefit you, and we will be really, really happy if you come and join us over there. If at all anybody of you is willing to kind of is convinced, and if you wish to join our Plus platform, please do consider using my promo code, that is drpawan-yt. You will get around 10% discount. At this moment, the 1 year subscription is available at 25k, and if you use this particular promo code, it will drop down to 22.5k. Just give me a couple of minutes, go down in the link. There is a kind of a link that will be directed towards my page. Please follow me on Academy so that you will get the kind of notifications of my courses. First thing. Another thing is, you will able to see whatever the courses which I have already launched in there. You will be able to have a glimpse of all the courses launched by all the other educators, and you can also see the dedications that the students have given regarding the coach, like the teaching pattern or the platform and in general. Okay, so please give me 5 minutes, just follow that particular link and do this particular thing. And if at all you wish to join it, please do consider using my promo code drpawan-yt. Okay, so it was indeed a pleasure, guys. Thank you so much. And yeah, thank you, Pooja. It was indeed a conduct more live sessions. I'll definitely do that, Harshita. Please come and join kind of the Plus platform if you will. I'll be more than happy. Right. Thank you so much, guys. Yeah. See ya. Have a great day. Bye. Happy studying.